You're listening to Who Said, a Cardiology Board Review series. No fluff, just facts.
This episode is about ventricular tachycardia. We'll go over definitions and paradigms in ventricular tachycardia. We'll talk about management of ventricular tachycardia, mechanisms, and we'll end with a section on how to distinguish why complex tachycardias, which may or may not be ventricular tachycardia, versus something like aberrancy from a supraventricular tachycardia. So let's start out with definitions and VTAC. A lot of these terms are thrown around, but it's important to know what exactly is non-sustained VTAC and sustained VTAC. So sustained VTAC is VTAC that is lasting for more than 30 seconds, or it can be VTAC that's less than 30 seconds that has hemodynamic instability. Non-sustained VTAC is VTAC that lasts more than 3 beats, but less than 30 seconds. Notice the units are different, so that confuses some people. Repetitive monomorphic VTAC is when you have episodes of non-sustained VTAC that continuously repeat. VT storm is having at least 3 episodes of VTAC in 24 hours, requiring intervention to terminate. Monomorphic VTAC is VTAC where all the beats have the same QRS morphology. Polymorphic VTAC is VTAC where you have continuously changing morphology of the VTAC that is seen beat to beat, whereas pleomorphic VTAC is having more than one distinct morphology during the same episode of VTAC. What do monomorphic versus polymorphic VT suggest? Monomorphic VT, which has a single QRS morphology from beat to beat, is suggestive of scar-related substrate from prior MI or a focal VT mechanism. This is a very high yield point. Polymorphic VTAC, which has multiform QRS morphology from beat to beat, is suggestive of changing ventricular activating sequence from current ischemia. Monomorphic VTAC with no evidence of scar can be from cardiomyopathy, such as sarcoid, ARVC, myocarditis. Monomorphic with no evidence of scar or his systolic heart failure could be outflow tract VT, fascicular VT, annular VT, Purkinje-related VT, or papillary muscle VT. We'll go over how to distinguish between all of these different sites as well within this episode. Polymorphic VT with no evidence of current ischemia or systolic heart failure can be from long QT syndrome, short QT syndrome, CPVT, or Brugada syndrome. What should you do if you see polymorphic VT? Check the baseline EKG. If normal baseline QTC, then the polymorphic VT is probably active ischemia. You'll want to treat the ischemia as soon as possible. PCI, possibly balloon pump. So your first thought for polymorphic VTAC should be, should you activate the cath lab now or not? Not even lidodrip or not. If the prolonged baseline QTC on prior EKG and there's no evidence of current ischemia, then the polymorphic VT is probably torsade de pointe or long QT syndrome. So you want to make sure all QT prolonging agents are discontinued, give IV magnesium or potassium if needed, prevent bradycardia by holding AV nodal agents and amiodarone, and consider isoproterenol. To this point, the 2021 ACC AHA SKY guideline for coronary artery vascularization says, in patients with ventricular fibrillation, polymorphic ventricular tachycardia, or cardiac arrest, revascularization of significant CAD is recommended to improve survival. That is a Class 1 recommendation. In patients with CAD and suspected scar-mediated sustained monomorphic VT, revascularization is not recommended for the sole purpose of preventing recurrent VT. Class 3, no benefit. What is VT storm? In a patient without an ICD, VT storm is defined as the occurrence of at least 3 hemodynamically stable ventricular arrhythmias, tachyarrhythmias, within 24 hours. Or if you have a VTAC episode that occurs soon, i.e. within 5 minutes of termination of another VT episode, that also qualifies as VT storm. Sustained and non-sustained VT resulting in a total number of ventricular ectopic beats greater than sinus beats in a 24-hour period. That is the third way that you can qualify for the definition of VT storm in a patient without an ICD. What about in a patient with an ICD? if you have occurrence of at least 3 appropriate therapies for ventricular tachyarrhythmias, including anti-tachycardia pacing or ATP or ICD shocks within 24 hours, that is the most straightforward definition for VT storm in a patient with ICD. But there are a few other ways that you can qualify for this definition. VTAC that is slower than the program detection rate of the ICD, that's not going to necessarily trigger an ICD shock, but you also need to recognize that. VTAC that fails to terminate with appropriate ICD therapy and remain undetected by the patient, that's also something you have to consider. And VTAC that occurs soon, i.e., within 5 minutes of a successful therapy being delivered. That also is VT storm. So, what are the medications you can give for VT storm? There's amiodarone, lidocaine, procainamide, and sotalol. Amiodarone is given 150 milligrams over 10 minutes as the bolus, followed by an infusion at 1 mg per min for 6 hours, then down stepped to 0.5 mg per min times 18 hours, achieving a total of 1 gram in 24 hours. You then give an oral load, such as 400 milligrams PO Q8 hours, overlapping IV for 24 hours to a total of 10 grams over 7 to 10 days. And then after that, you then step it down to the outpatient dose. Prolonged amiodarone infusion may cause hypotension and phlebitis, so you do want to switch to PO when able and not keep them forever on the IV version of amiodarone. Next, we have lidocaine. That's a class 1B antiarrhythmic. You give it as a 1 to 1.5 mg per kg IV bolus. Then you do maintenance infusion at 1 to 4 milligrams per minute. Eventually, when the patient stabilizes, you can transition to PO mexilatine at 150 milligrams Q8 hours. Note that lidocaine is very effective in ischemic tissue. Lidocaine works in the ventricle only, not the atrium, unlike amiodarone, which works in both ventricle and atrium. So if you have a concomitant supraventricular arrhythmia like AFib, amiodarone would help both the VT and the AFib, but the lidocaine would only help the VT. Lidocaine is also hepatically cleared. Next, we have procainamide, which is a class 1A antiarrhythmic. There are 3 options for a procainamide load. One is you can infuse 20 to 40 milligrams per minute until either the VTAC ceases or you get limited by hypotension or QRS prolongation by 50% from baseline, or a total of 17 mg per kg is given. The second option is you can give a 0.5 milligram per kilogram bolus every 5 minutes until a total of 17 mg per kg is given. The third option is that you can just give the entire 17 mg per kg bolus. After that load, you can give maintenance infusion at 1 to 4 mg per minute, adjusted for EGFR. So this is similar to the number 1 to 4 mg per minute as the maintenance infusion dose for lidocaine. Just make it easier for you to remember. Procainamide has no oral equivalent. Procainamide is only used if you can't do lidocaine or amiodarone, and it is renally cleared. Now, how about sotalol? Sotalol's IV load is 1 to 1.5 mg per kg over 5 minutes. So recall that lidocaine's load was also 1 to 1.5 mg per kg IV. And then you followed sotalol's IV load with a maintenance infusion at 10 milligrams per minute. So this is higher than the 1 to 4 milligrams per minute infusion rate for lidocaine and procainamide. So 10 milligrams per minute sotalol maintenance infusion. If you do an oral load, you can do it as 80 milligrams POQ 12 hours. And then you'll eventually up titrate the maintenance to 120 milligrams POBID and, if possible, 160 milligrams POBID. Of course, you need to do EKG for the first 5 doses, 2 hours post-dosing as an inpatient, because you want to monitor to make sure if you see any QT changes, you need to discontinue sotalol or half the dose in consultation with the EP. Amiodarone and lidocaine can be given in HFrEF, heart failure with reduced ejection fraction, whereas sotalol and procainamide should be avoided in HFrEF. Amiodarone and lidocaine can be given in patients with long QT, whereas sotalol and procainamide should be avoided in long QT. If sustained monomorphic ventricular tachycardia is found to have a normal echo and normal cardiac MRI, i.e. no scar, indicating a structurally normal heart, you should not place an ICD. You should focus on pharmacologic preventive therapy. Now let's talk a bit about ICD shocks. What are appropriate and inappropriate ICD shocks? Appropriate ICD shocks are delivered for malignant ventricular arrhythmia such as ventricular fibrillation, monomorphic VT, or polymorphic VT. In contrast, inappropriate ICD shocks are delivered in the absence of a malignant ventricular arrhythmia, such as supraventricular arrhythmias like AFib or sinus tach, electromagnetic interference, lead fracture or displacements, T wave or atrial oversensing, or muscle twitching. What should you do about ICD shocks? If the patient is unstable, meaning their blood pressure is affected, then just skip everything else, apply a magnet, and go to electrical cardioversion. If the patient has a reasonable blood pressure and it is recurrent VT that's appropriately being terminated by ICD, then you should continue to let the ICD work and then proceed to medical management of the VT storm as described by with the medications above. If there's no arrhythmia, but the patient is getting recurrent inappropriate shocks, that suggests that there may be lead fracture or displacement. You want to apply a magnet and place external pads in case they do have an arrhythmia that requires cardioversion while you figure out the etiology of the inappropriate shock, such as lead fracture. If you are seeing supraventricular arrhythmias and getting recurrent inappropriate shocks, then apply the magnet and treat the SVT. And potentially, you may be able to reprogram it as well to avoid detecting the SVT. Now, let's talk about mechanisms. What mechanisms of VT are at play? There's many different kinds of VT. It's not all one thing. Mechanisms of ventricular arrhythmia are enhanced normal automaticity, abnormal automaticity, triggered activity induced by early or late after depolarizations, and reentry. We explored this in detail in the episode dedicated to mechanisms of arrhythmia, but I will review the pertinent points here. The most common mechanism for ventricular tachycardia in patients with coronary artery disease is reentry. This is called scar-mediated reentrant VT and should be monomorphic. Acute myocardial ischemia causes reentry due to loss of the epicardial action potential dome in phase 2. Reentry requires a trigger to initiate the arrhythmia and a substrate to sustain it. The trigger may be a premature ventricular contraction, PVC, which may be in turn due to automaticity. The substrate may be structural remodeling secondary to an underlying disease process, either a scar secondary to a prior MI, or surgical repair or patchy fibrosis in the setting of cardiomyopathy or hypertrophy. Delayed after depolarizations are a type of triggered activity typical of idiopathic outflow tract VT. Delayed after depolarizations can occur with acute myocardial infarction or digoxin toxicity and may manifest as bidirectional VT, as seen in catecholinergic polymorphic VT. Early after depolarizations are seen in torsade de pointes in the setting of long QT syndrome and polymorphic VT in general. Abnormal automaticity can be seen in fascicular ventricular tachycardias. Delayed after depolarizations can occur with acute myocardial infarction or digoxin toxicity, as I mentioned already. Okay, now I wanted to do a little section on distinguishing the wide complex tachycardias because not all wide complex tachycardias are VT. Wide complex tachycardias are, by definition, any rhythm that has a heart rate more than 100 and a QRS with more than 120. So, other than ventricular tachycardia, it could also be some form of supraventricular tachycardia. SVT conducted with aberrant interventricular conduction can be fixed bundle branch block, rate-dependent bundle branch block, which is usually right bundle branch block, conduction via an accessory pathway, or atrially triggered ventricular pacing. So, how do we think about this? First, we need to know how to identify AV dissociation in VT. To prove VT, you need to demonstrate that there is AV dissociation on the EKG. There are 3 ways to see AV dissociation. 1 is P waves marching through. 2 is fusion beats, also known as Dressler beats, when a supraventricular and ventricular impulse coincide at the same time to produce a hybrid QRS. 3 is capture beats, a fully normal looking beat in the middle of VT when a sinus node transiently captures the ventricles to produce a QRS of normal duration. Another high yield thing to do is to identify positive concordance or negative concordance in the precordial leads. This means that all precordial leads must have either monophasic R waves or monophasic S waves, not both. And then you have morphologic criteria for VT. If it's a right bundle branch pattern VT, is there a monophasic R or a QR in V1? If so, that is likely VT. Is the R taller than the R prime of the rabbit ear? If so, that's likely VT. Is there an RS, small r big S, in V6, meaning that the S wave is deeper than the height of the R wave in V6? If yes, that is also likely VT. If you have a left bundle branch block pattern, then think of the following. Is the initial R more than 40 milliseconds wide? If yes, that is VT. Is there a slurred or notched downwards leg of the S wave in V1 or V2? If yes, that's VT. If this is the start of the Q to the nadir of the QS more than 60 milliseconds in V1 or V2? If yes, that's VT. Is there a Q or QS in V6? If yes, that's VT. The Brugada method is a four-step approach for distinguishing VT versus SVT with aberrancy. First, check for absence of an RS complex in all precordial leads. Look at V1 to V6. If there's no RS complex, meaning no transition from an R wave to an S wave, that suggests ventricular tachycardia. If an RS complex is present in any precordial lead, move on to the next step. The second step is to check if there's an RS interval that's at least 100 milliseconds in any precordial lead. Measure the interval from the beginning of the R wave to the nadir of the S wave. If the RS interval is 100 milliseconds or more, that supports a diagnosis of VT. If the RS interval is less than 100 milliseconds in all leads, then move on to the next step. The third step is to check for atrioventricular dissociation. If you see P waves marching through fusion beats or capture beats, that is diagnostic of VT. If no AV dissociation is present, then move to the final step. Fourth, go through the morphologic criteria for VT in the precordial leads. I gave you about 7 different morphologic criteria a few minutes ago, but example morphologies suggestive of VT include a right bundle branch block with a broad R wave, more than 40 milliseconds in duration in V1, or a left bundle branch block pattern with a broad S wave, more than 40 milliseconds in V6. If none of these 4 criteria are present, then it is SVT with aberrancy instead of VT. Other than a Brugada method, there's also a lead AVR method, which is a 3-step approach for distinguishing VT versus SVT with aberrancy. First, look at the initial deflection in lead AVR. If the initial deflection is a dominant R wave, that favors VT. If no dominant R wave is present, then we proceed to the next step. Second, look for a QR or R wave in lead AVR. This suggests that the impulse originates from the ventricle, causing an abnormal depolarization pattern that is reflected in lead AVR, thus favoring VT. If there is no QR or R wave in AVR, then proceed to the next step. Third, look for a deep S wave in lead 1, 2, or V6. If present, that supports the diagnosis of VT. If none of these criteria are present, then it is SVT with aberrancy instead of VT. I hope that makes sense. You can use either of these algorithms. If adenosine is given in a wide QRS tachycardia, VT should be unaffected by adenosine, whereas SVT with aberrant conduction should either terminate or be exposed by transient AV block. But before you do that, you must be sure that the patient does not have Wolff-Parkinson-White syndrome, because if so, adenosine may accelerate conduction through the accessory pathway. On EP study, VT can be distinguished from SVT with aberrancy by the HV interval. In SVT with aberrancy, the HV interval during tachycardia is equal to or greater than the HV interval during normal sinus rhythm. If the HV interval is shortened during the tachycardia, that suggests either VT or the presence of an accessory pathway. That's all for ventricular tachycardia. Come back to the next episode to hear about localizing the origin of ventricular tachycardia and premature ventricular contractions.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.